Thank you for your attention.
Thanks so much, Dr. DeMizio. We now understand a lot more about giant cell arteritis. At least I do. I'm sure the other two guests will have their opinion. And with that, I think what I'd like to do is turn things over to June for just a minute. Let you, June, if you can give us a 2 to 3 minute version of your story, and then you and Dr. DeMizio can throw some questions back and forth.
Sure, I'd be glad to. I started having headaches in October of 2018. My husband and I had just returned from a trip to Paris where we had been for 2 weeks. And on the plane coming home, the guy next to me was sick. So after we got home and I woke up with a headache 3 or 4 days later, I just figured, you know, I had whatever the guy had. And I have never had headaches ever. But the headaches continued through the week and were very severe. Finally, on Saturday morning, I went to an outpatient clinic. I was concerned that I might have a bleed of some kind. My headaches were so severe. They immediately ordered a CT scan. The diagnosis was sinusitis. I was placed on antibiotics. After 10 days of antibiotics, the headache was not any better. I went to see my PCP. He ordered some different antibiotics. That didn't do anything. And then finally, he did put me on a 6-day dose of prednisone. And my headaches, after 3 days, I didn't have a headache. Then after 10 days, the headaches returned. And then we went through all kinds of things, more sinusitis, talking about maybe allergies. And so for 3 months, this went on and on with the headaches. And finally, I did see a neurologist, and he and the PCP finally decided it might be time for a temporal artery biopsy. That day when I went to see my PCP, he said, you know, June, I'm thinking you might have some kind of arteritis. Now, I'm a nurse and I'm thinking, arteritis? I said, well, that doesn't sound very good, does it? And he said, no, I don't think that'd be very good, because already I'm thinking anything wrong with my arteries is not going to be great. So I had the temporal artery biopsy done by a vascular surgeon who I knew pretty well. And the next morning at 8 o'clock, my phone rang, and it was him. The pathologist had called and said, it's definitely positive. He said it was just classic what he saw. So the surgeon called my PCP. The PCP called and said immediately 60 milligrams of prednisone. Interesting enough, now my headaches didn't really stop like they had the first time. And I was, you know, I thought, well, in 2 or 3 days, it'll all go away. They did decrease in intensity, but I did continue to have headaches. And my vascular surgeon, when I had talked to him, he said, Jim, you might want to find a rheumatologist to manage this. And I talked to the PCP, and he didn't really have anybody in mind, but my husband was volunteering at Vanderbilt, and I had worked at Vanderbilt, and he came home with a little newsletter, and there was Kevin Byron, who had just come to Vanderbilt to start a vasculitis clinic. I thought, okay, here I go. And I found Kevin. And of course, he has just been my strength. I think the first time I went, he spent about an hour and a half. I went with a load of questions, some of which are certainly going to be talked about, I think, today. But in the meantime, you know, all the prednisone, I had worried about all the prednisone because I had, although it had been decreased to about 30 milligrams a day, I knew what the effects of the prednisone could be. So I was worried about becoming diabetic. I was worried about glaucoma. I was worried about weight gain. And so I started a program, and I decided I am going to come out of this as healthy as I possibly can. So I dropped my carbs really low. I started walking 3 miles every day to try to protect my bones. And I started seeing my ophthalmologist every 3 months. And I feel that I have been extremely fortunate. And eventually I was put on Ectemura, and there for a while, Dr. Byram gradually decreased then the prednisone while I was on Ectemura. And I'd say when I dropped to about 20 milligrams of prednisone and Ectemura, the headaches did go away finally. I continue to be healthy. I take my Ectemura by injection. It's now every 10 days instead of once a week. And to tell you the truth, I really don't think about it very much. You know, I'm healthy, I'm a gardener. I don't have any signs of PMR, thank goodness. I feel like I've been a real success story about this. And of course, you know, Dr. Byram and I talk about all the time about how long will I take the Ectemura? And I'm saying, listen, I will take this the rest of my life if I never have to go back on prednisone. So that's kind of my story. I don't know, are there questions?
That was great, June. That's a first very nice uplifting story. But also, I do think that probably brings up a few questions, but I'm going to ask Dr. DeMizio if he has any questions for you. And then I think you do have one for him. So Dr. DeMizio, you have anything you want to say or ask?
Yeah, June, I mean, thank you for sharing that story. That was very comprehensive and very useful, I think, for myself as a provider and for, I'm sure, patients that are listening. And I think your story is a classic one. I think, you know, presenting with those headaches and kind of this runaround for a little bit where you don't really know quite what it is. And, you know, is it sinusitis? Is it an infection, or are they just migraines? So I think that story is you're certainly not alone, but I'm very happy to hear that you had a very good course and are in fantastic hands with Dr. Byram. You know, one of the questions I had for you was in terms of the tocilizumab, were there any issues that you had with taking that? It sounds like you and along with several of my patients, I'm sure a lot of patients feel this way, they hate steroids, but how's your experience been with Ectemura with the injection?
It's been fine. You know, I was a nurse. I have no problem with that. In the beginning, I did have slight skin reaction, local reaction, but that pretty quickly went away. And of course, my labs are monitored on a 3-monthly basis, and all my labs are good. I mean, my SED rate is 1,
Good.
you know, and my CPR is way down. So
great.
no, it's of course the only thing about it is the cost.
Yeah. And the insurance aspects of it are murky, and sometimes it is a challenge, but it is a fantastic medication. I know a lot of these patients often are very nervous about the idea of injecting themselves or being on these medications. And I try my best to kind of allay fears, because it sounds scarier than it is. And absolutely all these medications have side effects. Are you absolutely going to be 100% and experience none of them? That can't be guaranteed, but I feel I'd rather you on Ectemura than steroids. That's
absolutely.
And I think most patients ultimately, when they come around and try the Ectemura, they're like, oh my gosh, it's like night and day. So that's good to hear. I'm glad you had no issues with it. And I think you have a question for me. Did I hear that correctly?
You know, of course, I always wonder if down the road, if you did another temporal artery biopsy, what would you find?
So that's a good question. It's not something that I do. It's not necessarily, recommended per se. Temporal artery biopsies are not necessarily all that involved. They're not benign, but they are invasive, and there's risk of injury. There's this risk of nerve damage. They tend to be, you're in, you're out. They're pretty benign, certain, procedures, and they do tend to improve after treatment. As I mentioned, we try to get these biopsies pretty quickly. We try to get them, 2 or 4 weeks, because you can notice changes. They can the inflammation could all go away. But there have been studies that, it's a great question. There have been some studies that they look into kind of these consecutive biopsies, getting a biopsy down the line. And, some of the biopsies show still having, giant cells present or damage to the vessel that's still present, many, many months down the line. But it might not, even though those changes might not be there, you might be feeling well, your headaches might be gone, your blood tests might be fine. So even though there's kind of those changes, it might not necessarily be indicative or showing that there's a relapse occurring or a flare occurring. So that's where I'm really excited because, that's where PET scans and CT angiography and MR angiography are really going to be useful, because you don't need to go in with that temporal artery biopsy again. You can just kind of look with the imaging and see if there's, kind of on a bird's eye view, a macroscopic view, a large scale view of, is there ongoing activity? Can we see any, visually, are there any issues that are arising, anything that might be leading to a problem down the line? Looking at it microscopically is useful, but it might not necessarily give us all that information. So I stay away from it. Some other people's practice might vary, but it's not something that I think is routinely done.
Yeah, that's what Dr. Byram says. Has there been any Have there been any post-mortem studies about people with GCA?
That's a good question. Not that I can think of offhand. There have been some studies that are like biopsy at initial diagnosis and then biopsy, let's say, at a time thereafter, X amount of months. And there are some biopsies that are still positive 6 months out. I think the longest I saw was a year and a half out. I'm sure that there are other studies, but I don't know about post-mortem for sure. I'm not certain about that. It's a good question.
Okay, well, thank you so much for the great questions and the answer that I think really was very thorough. So thanks so much, Dr. DeMizio. I think if it's okay with you two, we'll jump to John here and let him tell us his story, and then see if you have any questions for each other after that. So John, why don't you share with us today?
All right, can you hear me okay?
We can hear you great, thanks.
Well, my story starts almost 3 years ago. I've been keeping track. September 19, I woke up with what felt like groin pain. I thought it was from running or something like that, or something I'd done at workout. I dealt with that for a few weeks, eventually made an appointment with my primary care physician. By that time, it felt on both sides, just in that area, upper legs, hip area, groin area. Went through many appointments, physical therapy, all sorts of things, a little bit of blood work. Really dealt with this for almost 8 months before I walked off the golf course in between nines one day. I just couldn't move anymore. The mornings were brutal. Cold shower just to get moving. Rest, shoulder pain, hip, classic symptoms that you described, doctor. Wrote my physician a note on the portal. Got back to me immediately. Did a blood test. Called me back right after that. Elevated, highly elevated levels of C-reactive protein. Immediately went on I believe it was a 20 milligram dose of prednisone. Felt fine within hours. I mean, not days, we're talking hours. And so I immediately went on a taper, about a 10-month taper. As I was tapering, some of those symptoms were coming back, nothing near what they were, but I could start to feel it. Got off the prednisone after about 10 months. In the next couple of weeks, I started very mild headache. I never had that. And a little bit of jaw pain. And I'm starting to wonder, what's going on here? So I go on the Mayo website and just do a little research and found a few things there and said, it's time to fight my way into rheumatology, get an appointment, which I did. Saw my doctor. He immediately got things rolling. I went, the surgeon was calling me before I left the building. I was scheduled for a temporal biopsy. A few days later, positive. I was getting an Ectemura infusion within 2 weeks. Started on 60 milligrams of prednisone at the same time, tapered down to nothing within about 10 months. I believe I'll get my 12th Ectemura infusion next month. The plan is to continue those infusions, as far as I know, for another year at least. I've been off prednisone since December. And I guess I'm doing fine. You know, I have some issues, and I think they're more related to the spinal stenosis diagnosis, and I've been dealing with that with a lot of different ideas, everything from acupuncture to dry needling to, you know, an inversion table, which I found really helped a lot. And that is one of my questions, hanging almost upside down with all that blood rushing to my head. I don't know if I'm putting myself in danger with GCA or not, but that has really helped my back. Other than that, it looks like I should probably see an eye doctor, which I have not. As June has said, I seem to be doing fine. I don't think any of the issues I'm having in my legs and hips and things are due to GC or TMR. I think it has more to do with my spine issues and some things that are going on there.
Yeah, that very well could be the case. John, thank you for your story. Again, that's kind of a very interesting one where, again, you started with PMR, it sounds like, and then slowly progressed. And that certainly is something, you know, that we see. It's kind of this insidious something lurking in the background, and then the GCA presents itself. And it can be challenging, you know, these diagnoses and other comorbidities. It sounds like your spinal stenosis complicates pictures. And you know, it's hard to tease out some of these things sometimes, but the inflammatory markers, the SED rate, the CRP, those markers have all been well in your case?
Every 3 months I've tested and they've all been fine. Yeah.
Okay, great. Yeah, I mean, that does support your theory that it probably is not the GCA. You know, careful monitoring, looking at the symptoms. You know, I think seeing an eye doctor probably is prudent. But yeah, I think if you're not having visual symptoms, it's unlikely. But you know, it's always better to at least be teed in or you know, in line with an ophthalmologist. God forbid something happens in the future, you have like a fast line to get in touch with them. So I always do recommend that. Yeah, and thank you for sharing your story.
Yes, thank you so much, John. I think what we're going to do, if it's okay with all of you, I want to check with everybody quickly on their time. It's just about 5 o'clock now, I think, but we're going to go 10 more minutes, if that's okay with all of you.
Yep, that's perfectly fine by me.
Fine.
Okay, great, thanks. Okay, so at this point, what we'd like to do, we've gotten a series of questions from other patients from various social media sites and things, and we would love to ask you a few more questions.
Sure.
We've gotten some very good comments and questions already from Jude and John, but let's run through a few of these if that's okay with you, Dr. DeMizio.
Absolutely.
Okay, so the first one is, what is the difference between the symptoms related to TMJ and symptoms in the jaw that are typically related to GCA?
Yeah, that's a great question. It's really an important distinction. And the difference really is due to, you know, the mechanism of what's causing the pain. So TMJ, in case you're unfamiliar with the acronym, is a temporal mandibular joint. It's basically the jaw. And in TMJ pain, there really is kind of a mechanical problem. There's an issue with the joint itself. And this compares to GCA, where there's basically kind of a vascular occlusion. There's a blockage. There's a lack of blood flow that's not really getting to the muscles very well of the jaw, the tongue. So in TMJ, the pain typically occurs pretty rapidly, I would say. It even happens, you know, when chewing or talking, and there's often sometimes like this like audible click. You'll hear a grinding or a clicking sensation because the joint is essentially, you know, not functioning properly. And this compares to GCA, where it takes a little bit of time for that pain to start. It's not as immediate. It's not as abrupt. It's usually a few minutes, you know, after chewing or after talking for a while, that then the mouth starts to get fatigued. And that's because the muscles are not getting blood, and those muscles start to get fatigued. So that's kind of the major, you know, distinguishing features between the two, between TMJ and GCA. Good question.
That is a good question. It sounds like something your doctor would help you analyze and would come up with the right answer for which one it was.
Absolutely.
Another interesting one is, one of the stranger symptoms I've experienced a few months before my diagnosis was a chronic hoarseness, noticeable change in my voice. Can the doctor comment on whether this is a common symptom of GCA?
So it's not a common presentation having hoarseness, but it can occur. there's a couple of possibilities there. Basically, it can occur if certain blood vessels are affected. It's absolutely not common. So that's kind of the first part. But if there's aortitis, if there's inflammation of the aorta, there can be irritation. There's a nerve that kind of walks around in that area called the recurrent laryngeal nerve. And that nerve supplies the larynx, essentially where the vocal cords, where the voice box is. So if there's irritation to that nerve, it can lead to, yes, it can lead to hoarseness, it can lead to dysphonia, difficulty speaking, or a hoarse, raspier voice. It's got an interesting name. It's called Ortner syndrome. Fancy name basically for the hoarseness due to aortitis or a compression of the nerve. There also can be lack of blood flow. As we mentioned, that's kind of the driving way that GCA causes issues. So branches of the external carotid supply the larynx itself, and that can lead to basically lack of blood flow to the larynx, to the vocal cords directly, and that can lead to hoarseness and dysphonia. So there's kind of like two mechanisms, but it can happen, but it's not super duper common, no.
Understood. So an interesting question, I think, is I know you covered in your presentation that most likely doctors are looking for people presenting at over age 50 or above, but there is a question of what's the oldest and the youngest patient you've seen with GCA?
So it really is a disease of older individuals. The median age is around 70, and it's very, very rarely, though it does happen in patients that are less than 50. I would say the oldest that I personally care for, I think, is 96. Has been pretty well controlled for the past like 2 years. I think he was diagnosed when he was 94. I do have a handful of patients who are also in their kind of earlier 90s, but that's kind of the older group. And the youngest I have, I think, was 49 when she was diagnosed, like very close to her 50th birthday. Was with another provider when she was initially diagnosed. She's 51 or 52 now. That's the youngest that I have. So I think the youngest I personally treat is 51. But I know there are definitely case reports. You definitely will hear about it. Kind of, I think there was a case report of like a 17-year-old with biopsy proven GCA. It does happen, but I would say it's exceedingly, exceedingly rare.
Interesting question, though. Can you still have temporal arteritis if your inflammation levels are normal?
That's a really good question, and it's a pretty complex one. The short answer is yes. It's absolutely not common either, but it can and it does happen. In the vast majority of cases, I would say 95% of patients, 95% of cases have either an elevated ESR or a CRP, or both, 95%. So one or the other are elevated in about 95. Again, it's kind of an estimate, but about 95% or so. It's not all that uncommon that the SED rate is normal. So in about like 20% of cases, I would say, again, an estimate, about 20% will have a normal SED rate. But in those other patients, in those patients, in those 20% of cases where they're having negative ESR, the CRP is probably going to be elevated. It's much less likely, probably on the order of less than 5%, where you have completely stone cold normal SED rate and CRP at diagnosis. Again, it can happen. It happens with flares. It can happen at diagnosis, but it's not really common. And that's where those imaging modalities are really helpful, because in extracranial disease, it's not involving the temporal artery, you might have some light up of the aorta, for example, and that's how you make your diagnosis. So it is possible, but not exceedingly common either. Yeah.
Right. So any thoughts on, I know you addressed typical treatments that are being used right now with Prednisone and Ectemura. Any thoughts on any promising new things on the horizon?
Yeah, I mean, that's kind of one of the most exciting aspects of rheumatology. It's kind of why I went into the field, because compared to even 20 or 30 years ago, we have a ton of treatments that we treat our patients with now for other conditions like rheumatoid arthritis and psoriatic arthritis. I feel like every time I turn on the TV, like every other commercial is for like one of these biologic medications where people are swimming and fishing and having a great time, and they're absolutely like, they're hilarious, but they really work and they're great. So yeah, in terms of GCA, those same treatments that you're seeing kind of being advertised for like rheumatoid arthritis and psoriatic arthritis, those are all inflammatory conditions that there are ongoing trials with GCA that they're trying them in to see like, are they effective? And, there's a lot of clinical trials that are going on. There's a medication called abatacept or Rencia that's being looked into. It's an infusion or an injection similar to Ectemura. There's an oral pill called Rinvoq or upadacitinib. They all work by different mechanisms, different than what we see with Ectemura and tocilizumab. But, they seem fairly promising. The verdict is still out. Some patients, if they're refractory or if they're failing the tocilizumab or the steroids, we try these patients on these medications. And, I think the verdict, like I said, is still out, but there are a lot of therapies a little ways off, I would say, but we're trying these medications and making sure and seeing if they're effective in GCA. So it really is an exciting time. And I think June and John are testaments to it that Ectemura works, and it really does work very, very well. And it gets people off steroids. So yes, there are treatments on the horizons, but the one that we have now are pretty good.
Speaking of that, one of the questions we got, which I think we've sort of answered, but does Ectemura have side effects different from prednisone? I noticed that June said she didn't feel like she was having much difficulty with Ectemura. So
yeah. So does Ectemura have different side effects than prednisone is a good question. I mean, they're, in terms of similarities, they're both immunosuppressants. So they both kind of weaken your immune system. They both increase your risk for infections, things like upper respiratory infections, sinus infections, tuberculosis. The Ectemura does so a little bit more, I would say, for things like tuberculosis and viral infections like zoster, like shingles. But prednisone has kind of a litany of side effects. And, June had mentioned some of them. It makes it terrible insomnia, feeling, weight gain, blood pressure going out of whack. On long-term use, it can cause risk of fractures, osteoporosis, all sorts of issues. So prednisone, if you take it long enough, you're gonna get issues. Ectemura, you could take for years and years and years and not have any issues. So again, I'd rather you on Ectemura than prednisone any day. But is it wholly safe? I would say, there are risk factors with anything. There are side effects of any medication. We monitor labs pretty closely with Ectemura, with tocilizumab. There's risk of what we call cytopenias, or low blood counts, low white blood cell counts, low platelets, low anemia. So all of that is possible, but we monitor that, periodically. Every 3 months is what we recommend. There's risk of high cholesterol, hyperlipidemia that comes with tocilizumab. And then there's this really rare side effect. I always bring it up to my patients and I always consider it. There's this rare side effect of gastrointestinal perforation that scares a lot of patients, but it's quite rare. And I kind of screen my patients, make sure that they have no prior history of, perforations or diverticulitis. And in those sort of patients, I talk about it more seriously, but it's a side effect, but it's pretty rare. But I think by and large, patients have no issues with it. And I love the medication.
John, you had a question, it looked like.
I'm wondering, what do I look for in a flare? I mean, describe what I should be looking for, or what I should be doing if I experience a flare.
So flares vary from patient to patient. And for the most part, it's not really a hard and fast rule. But typically, if you're going to flare, it tends to be the symptoms that you had when you were initially diagnosed. So things like really severe headaches, really severe PMR-like symptoms, the joint pain in the shoulders and the hips, the groin pain, that tends to be what your symptoms are. If, it is possible that you have new symptoms, you start to develop fevers, you start to develop vision blurriness. You have to I would just be cognizant, do your research, speak with your provider, obviously, things that you should look out for, but it tends to be your typical symptoms that you initially diagnosed. There also is markers that tend to occur in the blood. So if the sed rate and the CRP are climbing and you're not feeling any symptoms, they're non-specific tests. I don't put too much weight into those markers elevating. If you have a cold, if you have a flu, if you have something, those sed rate or CRP are going to rise. But if those markers are rising and you're starting to develop symptoms, that's kind of a red flag that something needs to be done. Blood tests in isolation, they're just numbers, but the whole picture is important to recognize. Yeah. Does that answer your question?
Yeah, I think so. So most likely, if I do experience a flare, we'll probably be back to prednisone. But it's not an emergency situation, or is it?
Yes, likely the treatment would be increasing your steroids or starting your steroids, maybe changing the regimen of your Ectemura. Again, it's kind of individualized on what dose you're on and what the frequency is. The red flags are kind of newer symptoms, particularly if there's any eye symptoms. If you start to have that jaw claudication, if you start to have vision blurring, double vision, transient loss of vision, I would call your doctor, but I would be hightailing it to the nearest emergency room. And you don't fool around with the eye symptoms.
Thank you.
One of the things that I worried about, especially with COVID, when COVID hit, is I'm on Ectemura, how immunosuppressed am I? And so my PCP said, you know what, I won't do this for everybody, but I will test for you. And so 6 weeks after my second dose of Pfizer, they looked and I had no immunosuppression. I had a great reaction to the vaccine. So I just think that was pretty interesting.
Yeah, I think it is very interesting. It's kind of a moving target too. I feel like by the time I make my statement, the data will have probably changed. By the time this is posted, it'll probably have all changed by then. But it's a difficult question to answer. I would say that you are immunosuppressed. Patients on Ectemura on steroids are at higher risk from COVID. You're at higher, it's a harder time for you to fight that COVID if you get it. But is that necessarily, going to mean that you'd have a horrible time with COVID? Not necessarily. And Ectemura is not one of those medications that typically inhibits your ability to make antibodies to fight the things that we test for in a lot of these, for the vaccine effectiveness. It really, there are other medications that we use. One of them is called rituximab that really diminishes your risk of ability to make a defense against COVID and make antibodies protection against COVID. With that said, you certainly should still be practicing wearing the mask when in large crowds, trying to avoid people who are sick, washing your hands. The role of boosters, and that's a discussion in and of itself. And, I think we can go on and on and on about that, but there are great medications now, Evusheld being one of them. It's kind of an infusion that patients can get that, that can raise your immunity. There are post-exposure pills now, Paxlovid being one of them, and kind of the indications, who needs them, who doesn't need them. If you're someone on a high dose of steroids and on Ectemura, you might warrant Evusheld, which is one of those medications that can be given. I tend to reserve it really for that rituximab group, those patients that really can't make a good response, but that is a moving target. We're seeing it in my institution. We're using that for more and more patients as our stock improves. We were kind of saving it for the sickest of the sick, the ones who have real no immunity. But now, you are immunosuppressed. So should you get Evusheld? Should you have Paxlovid in your back pocket? I think that's debatable and it's a moving target. And the short answer is you're at risk, you're at higher risk, but how much, we don't really know.
So thank you for talking about that just then, Dr. Dinizio. And I just want to say for everybody else that's watching this webinar after we've recorded it, that we also the Vasculitis Foundation just completed a webinar a few days ago about those exact questions and Evusheld.
Perfect.
We do have some answers for you. So just go to the Vasculitis Foundation website and look for our most recent COVID-19 and the excellent forms of treatment that we have for it. And they discussed rituximab, patients also needing it more frequently than others. So that's a great resource for you. But good question, June. We really appreciate it.
Very good question.
And actually, so many great questions today. We appreciate all that you did, and having June and John on here helped us to have patients asking the direct questions. So we appreciate that. So I just want to say thank you on behalf of the Vasculitis Foundation to Dr. Dinizio, to June, and to John. And we're excited to be able to provide this education for other patients and physicians. So thank you so much.
Yes, thank you very much, June and John.